Shall we start, sir?
Yeah, please go ahead, Saroj.
Thank you so much, sir. Good morning and good evening, sir. And good morning, all attendees to being here. I am Ms. Sharma, host for this session. I request Dr. Somsekhar, sir, to start this session. Thank you, and over to you, sir.
Thank you. Welcome, everybody. Today we have one of a landmark talk from one of the leading expert in the world in this field. We have Professor Guilherme Pagin Juliao. He's a senior most colorectal surgeon at Angelita and the Joaquim Gama Institute, Sao Paulo, Brazil. He is also associate editor of Journal of Techniques in Coloproctology. He has several hundreds of publications. His special area of interest is colorectal, especially the wait and watch. And as you all read from himself and his institution, several publication, original work in the field of observation, wait and watch observation in rectum, in sphincter preservation and organ preservation. He has several international national accolades to his credit. He has also had a Robert D. Madoff Scientific award in 2018. He also had a Best Paper Award in ASCRS. He also holds the Robert World Best Award in 2019. He is also having a very good research award in Barton Hoekster ASCRS. And if you read his paper, it is amazing work which the Brazilian group is doing, which he and his team is heading. This is one of the most important topic, because in this era we have achieved organ preservation in most of the place. Like if you see a larynx, now the rule is organ preservation. But in a rectum, where the most important part, where the quality of life and sphincter preservation comes, yet we had not clear-cut guidelines until he and his group and his entire original work actually defined the guideline for us to do wait and watch policy. And especially now, as you know, in the last two ASCOs, using MSI, MMR and immunotherapies has revolutionized the treatment, but this is not one man's job. What are the guidelines, when to do, which are the patient, where you can do that. Like for example, this is an era of TNT protocol, total neoadjuvant protocol. So some institutions do short course, some do long course. As we all know, if we have a T4, N2, low rectum, if you really want to look for a PCR and wait and watch, a conventional long course radiation with oral capecitabine followed by all the chemo TNT protocol has high chance of
Thank you very much, Professor Som, for the nice introduction. It's a really honor to be here with all of you, and I hope you enjoy the next few minutes that I'll try to share our experience with watch and wait, which is quite a long history, and I'll try to put it all in a few slides to make it clear how we see it today and how we're been using it today for our patients. So as Professor Son said, I'm from Brazil, São Paulo. I am a colorectal surgeon. I'm going to talk about watch and wait and everything we need to know about it. I have been paid by Johnson & Johnson before for giving talks not related to this one here. But perhaps my main disclosure is that I am a huge support of Professor Angelita Haber-Gama, who is the one that pioneered watch and wait nearly 30 years ago, more than 30 years ago. So we've been working together for more than 20 years now, and I'm a great supporter of her, and perhaps this is my main disclosure. And to start talking about watch and wait, I need to tell you how Professor Haber-Gama usually says to everybody how she came up with this idea. So all happened in the early 90s when she was treating a patient with distal rectal cancer, And the patient had chemoradiation and then came for operation as was usual to be done. And she performed a perfect Miles procedure. The patient did really well after the operation. And when the pathological report came up, she went really happy to tell the patient that the patient had a pathological complete response. And this was a really nice surrogate of survival, which means that she was probably cured of her cancer, and she was very enthusiastic in saying this for the patient. But the patient was not happy. The patient looked at her and then did some faces, and then the patient said, "So, doctor, you're telling me that you put this stoma in my belly, I will need to live with it for my whole life, and you did not remove the cancer, there was no cancer." And this made Professor Angelista to think that perhaps not removing one single cancer cell for the patient perhaps not necessary. And giving stoma for patients is something that is really disturbing for them, because that's something that they really do not want to have over their lives. So this was the kickoff of her thinking on watch and wait. And for so long, she decided that patient that she did not see any more tumor, she would not operate straightforward. Instead of it, she would watch and wait for these patients. And if we look at data nowadays, and if we ask patients with rectal cancer what is their main concern, what they really want for their lives. So this was a survey performed in the US. And here, with being cured of cancer, perhaps more important than that is not having a permanent stoma. So even though we surgeons, doctors, we want to offer our patients the cure of cancer, we need to consider that for these patients, not having a stoma is a big deal. And if we can avoid it without harming our patients, with not putting these patients at risk of the cancer, is something that we need to consider. And we colorectal surgeons or oncological surgeons knows that distal rectal cancer patients are patients that are really at risk of having a terminal stoma. Even though nowadays we can do intersphincteric resections and coloanal anastomosis, if we look at that 10 years follow-up of patients with distal rectal cancer, nearly 1 in 4 patients will end up with an stoma, either because he had never closed the ileostomy, or because he had a recurrence, or because had anal incontinence. It doesn't matter, but they will end up with a stoma. So we need to put this on the equation of our treatment, that the stoma is there. It cannot be ruled out, even if we can offer this patient a intersphincteric resection, a coloanal anastomosis. And then we came to the chemoradiation treatment and how it all began. So the chemoradiation treatment was initially offered with the solely purpose of having better local recurrence or lower recurrence rate, better disease, local disease-free survival, with decreased toxicity, and this was clearly for all patients that were T3 or T4 or node positive. This was clearly demonstrated by this paper, the German trial in 2004. And what happened is that some of these patients that would go for chemoradiation with the proposal of having better control, better local control, and had nasty tumors like this one here. You can see a nearly circumferential tumor with positive nodes really close to the anorectal junction, would eventually had a complete clinical response. So we had the whole treatment, we reassessed the patient, and there was no more tumor there, as we can see here. Perhaps some deformation in the rectal wall, some whitening of the mucosa, some telangiectasia, but no tumor. And this is what we called accidental watch and wait, because we were not planning a watch and wait for this patient, but accidentally this patient developed a complete clinical response, and we decided to offer this patient watch and wait. And the main key of having a successful watch and wait is knowing how to define a complete clinical response. Because watch and wait is something that we should offer for patients with complete clinical response. And we should base ourselves on 3 pillars. First of them is digital rectal examination. This is the most important because subtle irregularities, small nodules, sometimes they do not show up in endoscopy, they do not show up on MR, PET scans, anything, but you can feel with your finger. And if there is something that you're feeling with your finger, be careful because this may have tumor there. So digital rectal examination is number 1. Number 2 is endoscopy. And we evolved quite a lot in endoscopy in the last few years because nowadays we can do NBI, near focals, we can look for small irregularities. While in the past, when Professor Habergamma started watch and wait, we mainly did rigid proctoscopy for this patient, which is quite difficult for a very low tumor that usually we need to do a retroflex view like you're seeing here, because then you can properly look at the scar. There is nothing there, just some whitening, some telangiectasia, and this is a complete clinical response. You can see that there is no ulcer, there is no nodule, no mass, no stricture, because complete clinical response should not have all these features I just said. And then we came with the radiological staging. And by radiological, I mean magnetic resonance. So this is the 3rd pillar. We need to perform it for all patients we're planning to include in a watch and wait protocol to define the complete clinical response. And more important than defining the complete clinical response at the primary tumor, which we had already assessed with the finger and with the colonoscopy, is looking at the mesorectal and the lateral compartment to make sure there are no residual nodules there, the residual deposits or EMVI that it seems to have incomplete response. Because in the scenario where there is incomplete response in the mesorectal or in the lateral compartment, this patient is not a complete clinical response and should not be offered watch and wait, but should be recommended to have operation. One thing that we usually do not use to define a complete clinical response is endoscopic biopsies. So sometimes you can find some irregularities like we're seeing this rectoflex view, and we may be tempted to do some biopsies to make sure there is or there is not tumor there. The big issue with these biopsies is that if they come back as negative, they usually are not negative. They are false negatives. So we're seeing something that we call a near complete response, but not a complete response. Doing the biopsy should not be used to consider it a complete response, to consider this patient for watch and wait. Instead of doing biopsies for these patients that we believe it will become a complete clinical response, but it still is not, instead of doing biopsy and trusting our biopsies, we usually use time in our favor. So we know that radiation effect in the rectum is time dependent. And when we looked at our patients that were included in the watch and wait protocol, never had a local relapse or a local regrowth. And we looked at how long they took to show a perfect complete response, fulfilling the three pillars I just said for you: rectal examination, endoscopy, and MR. We saw that the vast majority, 73%, took more than 16 weeks from radiation therapy. And usually we assess this patient at 8 and 12 weeks. And remember that when we're talking about this, TNT was not fully implemented as it is today. So usually this patient just had long course chemoradiation with just some chemotherapy over the radiation period. And these patients took usually more than 16 weeks to become a complete clinical response. So a patient like this, at 12 weeks, I assess there is some residual ulcer, but I cannot feel with the finger. The magnetic resonance says there is no tumor there, but the endoscopy says there is something wrong there. Instead of doing a biopsy here, I just wait a bit longer, and if it is really a complete response, it will become a clinical complete response. So no biopsies giving more time. But the big problem with near complete response, and it's very important to clarify this here, I'm not telling you to offer patients with near complete response watch and wait. What I'm telling you is that we need to give some more time before taking the full decision, is that the definition of near complete response is difficult to have. Different from the complete clinical response, which is the whitening mucosa or the whitening scar, no ulcers, low signal intensity on the MR. This is clear for a complete clinical response, but for near complete clinical response, there is not a consensus on how to define it, either from the endoscopic point of view or the magnetic resonance point of view. So after expert consensus, what they come up, which is not the definition, but is some statements that I believe is quite important, is that this near complete response should only be used temporarily. So it needs to evolve to a complete clinical response, or you need to operate it. You should not be looking at a near complete response for too long. And when I say too long, they come up with the 6-month deadline. So after the end of radiation, you have a near complete response, which I tell you, be careful. There is not a proper definition. If you're in doubt, don't do anything stupid here. Just go and operate, do something surgically. But if you believe this is a complete clinical response, but still there is some irregularity that it will become a complete clinical response, so reassess this patient closely in 6 weeks, 8 weeks, and no further than 6 months from the end of radiotherapy to make a decision. If it becomes a complete clinical response, then we're back to the watch and wait strategy. If not, we need to do something else. So accidental watch and wait. We stratify our patients. They have high risk features on the MR, and we offer this patient long course chemoradiation, and eventually they will have a clinical complete response, and we will offer these patients watch and wait. What are the outcomes of this patient? So nowadays there are several studies, meta-analysis, systematic reviews, many institutions, and they show pretty much the same outcomes, which are, if we had a clinical complete response and watch and wait, and compared to patients that were operated and had a pathological complete response, or even those that had a clinical complete response and were operated, they had the same oncological outcomes. which means we're not harming these patients. We can do this with the same outcomes as if they had a pathological complete response or if they had a clinical complete response and were operated. The big problem in doing watch and wait is that we know that during follow-up, some of the tumor will regrow. What does it mean? They will reappear in the same place they were from the beginning. So we'll have a complete clinical response, and then we're gonna reassess this patient in 2 months, and then in 2 months again, and then in 2 months again, and eventually they will reappear like a tumor again. What is important about the regrowth? They usually regrow in the rectal wall. So it's very unusual to have a regrow exclusively in the mesorectal. So yes, we do MR to follow up this patient, but more important than doing MR is to doing digital rectal examination and endoscopy. Because if we're offering this strategy for a very low tumor, if we do a digital rectal examination, we can feel the regrowth. And usually is the first tool to detect a regrowth is digital rectal examination, which is not expensive, which can be done in the office. How often does it happen? So again, different studies, usually the International Watch and Wait database or a systematic review with pooled analysis showed a rate of local regrowth in 3 years of 22%. So usually goes from 22% to 30%, the rate of regrowth over the whole follow-up. Can we predict a regrowth? And the answer is no, we cannot predict a regrowth, but we have some tips. So one of them is baseline T staging. We know that tumors that had a baseline T staging T2, which is an early tumor, they have a very low chance of having a local regrowth after a complete clinical response. So nearly 96% of patients with a complete clinical response that were initially at T2 will not have a regrowth, while patients with T3 and T4 are at increased risks of having a local regrowth. So this is important when we have a patient included in the watch and wait follow-up, just to estimate the chance of him having a local regrowth. So again, the same data showing that T1, T2 had lower rate of regrowth, but here in a large number of patients, so 600 patients in this meta-analysis of 11 studies, showing that as the T stage increase, the risk of having a local regrowth also increase. And this is perhaps the more important information regarding regrowth in concerns of predicting the regrowth. So baseline T stage. But after the first year of follow-up, it doesn't make any more difference. So the chance of having a regrowth, it doesn't matter anymore if it was a T2, T3, or T4 after the first year is gone. So in the beginning, Professor Angelita used to say that we need to be really strict in the first year because this is when the regrowth reappear. And this is true. The majority of the regrowth will reappear in the first year, and as we can see here, it in this first year is more frequent in T2, in T3 and T4 than in T2. But nowadays we know that's not only the first year, but the first 3 years. So the first year is the year that has the higher incidence of regrowth. But the information I wanna give you is that after 3 years without a regrowth, the chance of having a regrowth is less than 5%. So usually, and we are asked for how long we follow up this patient and how we follow up this patient. And after we've done this study, we changed it a bit because we usually were really strict in the first year. But then we decided to be strict for the first 3 years. And then after this, that the chance of having a local regrowth is less than 5%, we can perhaps go back to regular follow-up as this patient was operated. So instead of doing every 2 months or every 3 months, so this is the rate of follow-ups we do in the first 3 years, every 2 to 3 months, we do digital rectal examination, endoscopy, and MR. Once we complete the third year, we can do it 6 monthly or yearly, okay? So after 3 years, the chance of having a local regrowth is much, much lower. And then we come with the question, if once we have a local regrowth, can we do a salvage operation? And the answer is yes. So all the papers demonstrated there is a high chance of doing a salvage operation and of it being really successful. And one of the myths that we've heard in the past is that doing a TME after so long time after chemo radiation, like 19 months in this case, would be nearly impossible. And you can see in this video from a TME of a regrowth that this is not true. And this happens for all the patients. So if the patient is doing the proper follow-up, is being followed strictly, when we find out a regrowth, usually it's a small regrowth. That's why it's resectable. It's in the same place and you can do the same operation you would do before. And the TME plane will not be compromised, it will not be difficult. What makes an operation difficult after so long after chemoradiation is if you're dealing with a huge tumor. Because what sometimes happens is that patients that do not have a complete clinical response are not operated for many reasons, and then they come back for the operation many months later with a huge tumor, and then you had nasty planes and difficult operations. And the fault is not the time, but the size of the tumor. So for a regrowth that had been followed properly, not big issues to perform the operation after so long time after chemoradiation. So as I said, 95% local control, what that means. So 30% of local regrowth we had during follow-up, and then this patient was salvaged, and only 6% had further recurrence or were not able to be salvaged either because had systemic disease simultaneously or because were not fit at the time of the operation. So it's quite good control. What about doing further organ preservation after a local regrowth? So this is also possible. Nowadays, the desire for organ preservation is quite high, and there is huge interest in local excisions with full thickness local excisions. And there are even institutions that instead of offering watch and wait, offer local excision for this patient, which I will not discuss this right now because there's good and bad points of views. But what I want to say is that if a patient had a local regrowth that is restricted to the rectal wall, what I mean is that is probably a T1 or a T2 with no mesorectal disease, a small one like this one here, we can still offer this patient local excision and organ preservation. So it's not because he had a local regrowth that we're not doing the organ preservation anymore. And when we compare the outcomes of these patients, so patients that were treated with further organ preservation and that those that do not have an organ preservation for the treatment of local regrowth, using our patients from Brazil and patients from Champalimau institution in Portugal, we saw that there was some selecting bias, as I mentioned, because we offered organ preservation for early tumors. So they're more likely to be early cancers, and reflected in better outcomes after the operation. So those patients that were treated with local excision, in fact, had better outcomes than those that were not treated with organ preservation but with radical operation, probably related to the selecting. But this shows us that doing the organ preservation or the local excision did not harm these patients. And what about the systemic recurrence? So this is something that raised our concerns recently, and I will explain why. So a few years ago, the group from Memorial published this paper on JAMA showing that patients who had watch and wait and local regrowth had a rate of systemic recurrence of 36%, which was extremely high, much higher than those that had successful watch and wait or those that had a pathological complete response. And then we said, whoa, this is disturbing. So we looked at the International Watch and Wait database, which is a database of several institutions, over 50 institutions around the world that include patients that are being treated with watch and wait, and looked at the patients that had systemic recurrence and find out that the only risk factor for having a systemic recurrence, a distant metastasis, was having a local regrowth. So having a local regrowth is not good, is in fact really bad for the point of view of systemic control, even though we've just seen that local regrowth can be salvaged, can have a very good local control after the operation. Systemic is a bit concerning. And then we again performing the conditional survival. We usually follow a patient after a rectal cancer or colon cancer or other kinds of cancer for 5 years, because we know that the risk of having further recurrence after 5 years is quite low, as you can see here in the yellow line. So less than 5% after 5 years. So usually we say after 5 years, if you did not relapse, probably you cured. With local recurrence, with local regrowth, is different. So usually patients with local regrowth, they had a higher chance of having systemic recurrence for more than 5 years. Again, you can look at the yellow line here, and it's more than 10% of risk of having a further recurrence or systemic recurrence after 5 years of follow-ups. So this make us think about it, and we came up with this theory of second hit. So the theory of the second hit, which is really important for patients with local regrowth, basically is that once we have the baseline tumor, the primary tumor is the first hit. This is the moment that the tumor is spreading, you have a higher chance of having systemic dissemination. And then you have the treatment that had a complete clinical response. And if you have a successful watch and wait, that's it. The chance of having a systemic recurrence is really low. But there are a few patients that will have a regrowth. What that means, that we're gonna wait 1 year, 2 years, sometimes 3 years to discover that the truth is that this patient never had a complete pathological response, because a regrowth is not a new tumor. It's the same tumor that stayed in place for a long, long time. And perhaps we've just selected the worst cancer cells with our radiotherapy, and these are the ones that start growing. And then we had a second hit, because the tumor got some size and some potential of systemic dissemination. And then instead of considering time to follow up our patients after a local regrowth, instead of considering the time of the treatment of the baseline tumor, we need to consider the time of the treatment of the regrowth, because this works as a second hit. And then we come with the comparisons. So watch and wait and regrowth, definitely worse than those that had a complete response and had a successful watch and wait. And we thought about this many years ago. So what's the issue of operating a patient longer than straightforward after chemoradiation at the time of regrowth? So they're both incomplete response, as I just said, because the tumor was there and it grew up. So what's the difference? So when we looked this in 2008, we saw that there was no difference of those patients that were operated straight after chemoradiation with incomplete response to those that were operated by the time of the local regrowth. So no oncological outcomes. And then the OPRA trial that was published by the group of Memorial also showed the same thing. So patients that were operated at the pre-staging had the same outcomes of those that were operated at the time of the regrowth, showing that there was no oncological compromise. The problem is that, in our opinion, this is not a fair comparison. It's not a fair comparison because we're talking about a patient that straight after chemoradiation had a clinical complete response, therefore it was included in the watch and wait and had the chance of having a local regrowth, to those that had a minimal response or even no response. So it's not fair because this was excellent, had extremely good response, and those did not. So we decided to make a different test to look differently to this patient. Instead of comparing these patients that were operated at the time of regrowth to all incomplete response, we selected only those patients that were operated at restaging but had minimal amount of residual cancer cells, as we believe it may be at this time here. Probably there is minimal amount of residual cancer cells here. Of course, there are a few bias related to immortal time bias and everything, but it's a way we find out to look at these patients. And what we saw is that those that were operated by the time of local regrowth, they had a higher incidence of systemic recurrence than those that were operated immediately, nearly double or double, as you can see here. And the time to systemic recurrence was also longer, again showing or demonstrating or supporting the theory of the second hit that I explained for you earlier. So this was done with our patients, again, patients from Champalimaud institution compared to those from France, from Dr. Dedust. But we need more numbers to demonstrate this. So we came back to the International Watch and Wait database and compared to those that were operated in the Vikingo study. So I explained already for you the International Watch and Wait database, but now I'm going to explain the Vikingo. The Vikingo is a Spanish database that is trying to standardize the rectal cancer treatment in Spain. So all patients had baseline staging properly, TME, and proper pathological assessment of the specimen. So from this database, we retrieved nearly 900 patients that had TME with less than 10% residual cancer cells, and compared to those that had local regrowth in their International Watch and Wait database. And we can see exactly the same thing we saw in our small numbers. Patients that were operated by the time of local regrowth had worse distant metastasis-free survival when compared from the time of watch and wait and when compared from the time of the operation of the local regrowth. So showing that patients that have a local regrowth, they have, yes, a higher risk of having systemic disease during their follow-up. Therefore, we need to be really cautious with these patients. We need to lower our threshold in offering perhaps some further adjuvant treatment for this patient, even though we don't have studies yet to support this statement. When we look back at the OPRA study, the OPRA study included in the watch and wait strategy either patients with clinical complete response and patients with near complete clinical response. And even though they did not compare those patients with regrowth to those operated and with minimal residual cancer cells in the specimen, when we look at this secondary analysis of OPRA, and we look at the rate of systemic recurrence on patients that were operated at the time of regrowth after a clinical complete response, we can see that the chance of having further systemic recurrence is nearly 30%. Compared to those patients that had TME at the time of restaging and had a near complete response, had a chance of having systemic recurrence of 15%, which is pretty much the same numbers we've shown in both studies, either from disease or from JCO. So, watch and wait for near complete response is something we really need to take care. So, just this year, the group from Memorial, along with the group from Germany, joined their data to show the outcomes, the systemic outcomes, because they were provoked, to show that watch and wait was safe from the point of view of systemic recurrence. What I think it is safe, but we need to take care, really careful with the regrowth patient. We need to be obsessed in find out which are the regrowth patient and lower our patients the more we can to not having a regrowth. That means selecting properly those that will have a watch and wait strategy. So they compared patients that were included in the watch and wait after a near complete clinical response in the Ultra trial, and compared to those that had TME at restaged with intermediate response, which is pretty much the same thing we've done in our study, and demonstrated there was no difference among them, either regarding distant-free survival or distant recurrence-free survival. And the problem in comparing the near complete clinical response that were included in the watch and wait is that not all of them will have a regrowth. So we're comparing 50% of patients that in fact were pathological complete response but did not have a complete clinical response yet, together with the regrowth. So our concern is be careful with the regrowths, because they may have a higher chance of having systemic disease. So this is what we know when we talk about accidental watch and wait. Those that have high risk features, had long course chemoradiation, and then have an accidental clinical complete response. In summary, we need to find out a clear clinical endoscopic and radiological evidence of clinical complete response to recommend the watch and wait. Near clinical complete response should be managed with caution. Remember, we don't want to offer this patient watch and wait and find out that the near complete response in fact is residual tumor. Regrowths has low incidence on early tumors, and regrowth usually are amenable of salvage surgery with very good local control. And the problem seems to be that these patients are at increased risk of metastatic disease. And then we come, I'm just getting to the end, I know you're probably tired, to the new possibilities. So instead of having accidental watch and wait for everybody, we're gonna move to intentional watch and wait. So we're gonna identify patient that has higher chance of having a successful watch and wait, and we're gonna do a proper treatment for them to have their organ preservation, to have watch and wait. And how to select this patient? So we do MRs. We know that local regrowth is very unlikely in early tumors, so we'll try to identify early tumors, T2, early T3 tumors that want to have organ preservation, that want to go through the process, and then we'll offer this patient TNT with the idea of boosting their treatment and have the most response we can have. And we're going to select only the ultra low tumors, because these are the ones that really benefit of not having a stoma, because if they go to the operation, they have a higher chance of having a stoma. And this is exactly the landmark we use to select the patient. Usually we use MR to select our patient and not only digital rectal examination to reproduce the height of the tumor. And those that are a bit higher like this, they are 5 centimeters, 4 centimeters from the anorectal junction, we would probably offer a straightforward operation because these, as I said before, are early tumors. So those that are really low, we offer chemoradiation. And we've been doing this for a while now. And as I said, we do TNT because when we compared our regimen of long course chemoradiation only with 5FU to our TNT program, which is 5FU on a higher dose during chemoradiation and then during the rest period, we saw that in T2 and 0 patient, the chance of having a successful watch and wait is nearly double. And when we look again with the OPERA trial, they had nearly 50% of clinical complete response when successful watch and wait with both groups, the consolidation and the induction group, which is pretty much similar to our 62%. So we came up with the idea of performing a randomized trial, which is ongoing in our institution. So this is a multi-center randomized trial that any of you that want to be part of it, you can text me, send me a message, and we'll make it happen. We're gonna randomize patients that had not so advanced tumors and are really, really low tumors to have long course chemoradiation, and instead of closing that the TNT will be with full FOX for everybody as in the OPERA trial, we'll randomize them to have 2 drugs, 5FU and oxaliplatin, or 1 drug, capecitabine, in the other arm. Because we believe that perhaps the rates of clinical complete response and successful watch and wait will be similar among these 2 groups, and will have less toxicity if we omit the oxaliplatin. So just to finish, watch and wait, intensive follow-up in the first 3 years, every 2 months, every 2 to 3 months, and then after that we can soft a bit for every 6 months. As I said you before, even though we have data showing that the chance of having a regrowth of recurrence after 5 years is much low, we keep following these patients for longer and longer. We had case report of regrowth after 7 years, 10 years, which is really unlikely, but it may happen. So therefore we keep following this patient for longer and longer. So just to conclude my summary, think in watch and wait before you think about TNT. We need to consider that there are patients, there are good candidates for watch and wait, especially those that we would perhaps offer straight operation. And if they're really low ones, really low tumors that has a higher chance of needing a stoma, perhaps a definitive stoma, this patient may benefit of trying a watch and wait. So the good surgeon knows how to operate. The better surgeons know when to operate, but the best surgeon knows when not to operate. It was a pleasure to be with you here this evening, or this morning for you. This is my email. You can contact me, any of you that you want to share opinions and be part of our trial. These are photos from our group. Professor Angelita is really happy. Just talk to her. She remember very much when she was in India. She'll send her regards to all of you. And I'll be happy to listen and to answer some questions from you. Thank you very much.
Thank you, Professor Guilherme, Juliao. What a wonderful talk, always to hear from the original investigator, and especially somebody who has gone through the journey of the whole change in the paradigm shift in the rectal cancer treatment. It's like absolute pleasure, especially the way you summarize the existing trials, past trial, other trials, and your thought process of future, how to do that, when to do it, and integrating in this era of advancements in the systemic is superb, thoroughly enjoyed. And then you can see there is a full attendance and a lot of questions are coming in the chat box. Thank you very much. Lovely presentation. I will try to take some questions for you. So Akela Fanindra has asked, sir, EMV1 was proposed as a predictor of systemic failure. So does pre-chemo radiation presence. Does this influence the decision making for you in wait and watch if complete response is achieved?
No. So the main surrogate of having a successful watch and wait is having a clinical complete response. So if this patient had an EMVI or had a lateral node involvement or had a tumor deposit, had the treatment and had a complete clinical response, this patient will be a candidate for watch and wait. And he does not have an increased risk of having either local regrowth or systemic recurrence. The only factor that influences the risk of having local regrowth is baseline T staging. So if T staging is T3, even though we would do the watch and wait, knowing that there is a higher chance of having a local regrowth, but no matters.
Okay, thank you. Rutul Patel is asking, salvage surgery after local regrowth versus upfront surgery after neoadjuvant chemo RT. Final results are the same?
The same. Pretty much the same. Usually, as I said, the local regrowth, we operate small tumors because we identify them very early, and therefore sometimes the operation is much easier than operating an incomplete response and a bulky tumor. But the results are pretty much the same. And we have some data published already comparing the functional outcomes and all of these regarding the operations. They're pretty much the same.
Fantastic. There is a question from Dr. Jagannath Dikshit. Is a very senior robotic GI and colorectal surgeon. Sir, excellent presentation. Congratulations. Fantastic talk. I want to know, do you do frozen section for local excision after a residual small lesion? If so, what would be the margin you would like to aim in the final histopathology? That is the first question. You can answer, then I'll come back for the second.
Okay, so we do not do frozen section for local excision. We know that there is some tumor fragmentation when they have a response or even when they regrow, and therefore we need to have at least 1 centimeter margin, radial margin for these lesions. But when we look at the specimens, we want to have clear margins. So even if it's less than 1 centimeter, but when we're performing the operation, we want to offer this patient 1 centimeter margin. And our pathologists always include the whole specimen to make sure there is no tumor fragmentation or small nests of tumor cells apart from the main tumor, because this may happen.
Second question is MRI assessment reporting analysis is a very important part in the rectal cancer. So in your institution, what do you think to get an unbiased equivocal adequate report? How many radiologists should do MRI in the beginning phase, and once the institution matures and you have an expert MRI rectal protocol analysis, what should be the number of radiologists, you think, to read that?
So this is a great question, and this is a main issue everywhere in the world. Okay, so in our institution we have one radiologist that perform all the MR from the rectum. There are a few others in São Paulo that are good ones, but if the dedicated radiologist is not involved with the test will come rubbish and we're gonna repeat it. And this, as I mentioned, this happens everywhere in the world. You probably know Professor Gina Brown from the UK, and she's running recently Mercury 3 because she wants to implement this in the UK. So they cannot have this good in the UK as well, because usually the radiological department, they do not have this algorithm to say this is a rectal cancer, this needs to go to this doctor. So this is a big issue. My advice is complain. Say to the radiologist that you need to repeat your test until you get a good test. If we do not complain, the radiologist will think they're doing a good job. The radiological department will think they're doing a good job, and things will not improve. So it's part of our job to complain about bad MRs.
Fantastic. There is a question from Krishna. What percentage of complete responders eventually have local regrowth? You actually covered it. Maybe you can re-emphasize it.
Yeah, around 20 to 30%. But this is with accidental watch and wait. If we do the intentional watch and wait, which means selecting the early tumors, we want to decrease the rate of local regrowth, and we can do that.
Fantastic. There is a question from Dr. C.N. Patil. He is a very senior medical oncologist. He heads the Aster International Institute of Oncology in Bangalore cluster. He has a question. How do you integrate short course RT in wait and watch protocol?
There are some data, recent late data incorporating short course, but we do not perform short course for all patients. We do long course for all of them because we have better response, we have less toxicity, and the truth is that we have more and more data with long course chemoradiation, and it has always been our practice. So here in our institution in Brazil, is not common to perform short course radiotherapy. So I don't have patients from ourselves with watch and wait after short course, even though I've seen from other institutions patients in the watch and wait protocol after short course.
It's almost a similar question from Dinesh M. So now you answered it, because now we have clear-cut evidence that the TNT protocol with short course has a very good result, and it cuts down the duration of the treatment, and systemic metastasis actually comes down with a survival benefit. So if an institution, like in India now, most of the institution, like in UK and other European country and US, are switched over to short course radiation, other than the selected cases which are very low rectal, N2, T4, where conventional long course is done. If an institution is doing short course RT and also obviously long course is there, what do you recommend, how to integrate that actually in wait and watch? You told me in Brazil you're doing, but like you take a patient in India, US or Europe, where most of them get short course. So where do we use long course, where do we use short course in wait and watch?
So I do not share the same thoughts about the good outcomes of short course with TNT. So even though the Rapido trial showed better disease-free survival for those patients who had the experimental arm of short course and long and chemotherapy, consolidation chemotherapy, they showed the worst local control when compared to standard chemoradiation. So the second publication of Rapido clearly demonstrated that patients that had the experimental arm had worse local control than those that had chemoradiation, even though they had more pathological complete response, even though they had the same baseline staging. So it's not good in our opinion. We do not offer short course because we do not believe in it. We don't think it's good. And nowadays, what we're doing is that we're selecting more and more those patients that really benefit TNT. So if we had a mid-rectal tumor, T3 node positive, clear MRF, we would take them straight to operation. We would not do TNT for this patient because we believe he did not need TNT, as has shown by many prospective studies that these intermediate tumors can be treated with upper front operation. But if he has a very low tumor that we want to offer this patient watch and wait, we want to give him the best treatment, the best chance of having a complete clinical response, and then for a watch and wait, which is long course chemoradiation and consolidation chemotherapy.
Fantastic. So Raviraj has a question. What do you say are absolute contraindication for wait and watch, and what are the relative? Obviously, he meant even though they would achieve complete response, when you start, is T4 an absolute contraindication to start with, even if they achieve? So with your experience, absolute and relative contraindication for wait and watch before you start offering that.
So there is no absolute contraindication for watch and wait. So the majority of the data I've showed you today is about accidental watch and wait, which is usually for patients T3 and T4, because these are the patients that usually had TNT or long course chemoradiation, because in the past was long course chemoradiation only. So this data we have more robust nowadays is for patients with T3 and T4. But we believe that the best candidates are the early tumors. So there is not an absolute contraindication. Perhaps the absolute contraindication is not having a complete clinical response. If the patient has a complete clinical response, he is a candidate for watch and wait.
Thank you. And Raviraj has a question. As we know, in 20% of the patient, accidental wait and watch, if they have a local recurrence alone small, which T and N status should we consider? The prior treatment or now the regrowth TN status?
So we like to look at both, of course. So we want to make sure where there was tumor in the baseline. I mean, if there was any nodal disease, any lateral nodal disease, apart from the primary tumor, which the baseline is the best information we can get. But when we're going to decide what operation to do for the local regrowth, we consider the actual staging. So at the moment of the regrowth. So if at the moment of the regrowth, the tumor, we have let's say, a clear intersphincteric plane, it doesn't matter if in the baseline the plane was threatened, we would offer this patient a sphincter preserving procedure. If he is a candidate for a local excision, for example, but in the baseline he had some nasty nodal disease, perhaps I would not consider this patient for local excision, even though in the actual MR there is no nodal disease. So it's a merge of the two tests. We always consider both tests. We discuss the possibilities and the risks with the patient, but usually we consider both tests regarding margin, regarding planes, the actual plane, the actual exam, the actual test at the moment of the regrowth.
Thank you. There is a question from Ranveer Singh Rana. How do you decide whether to go for local excision or a complete TME in case there is a not complete response or a regrowth?
So it's a perfect and great question. So in my opinion, organ preservation are for those patients that had very low tumor. So the first criteria is having a very low tumor. So if it's a mid-rectal tumor and had a near complete response, TME. But if it's a really, really low tumor, then I would consider him for local excision. And to add to this equation, I would consider the baseline and staging that this patient had on the MR. So if he had nasty baseline and staging, I would not be comfortable to offer this patient with incomplete response only local excision. I would probably offer this patient TME, perhaps with an intersphincteric resection because it's a really superficial tumor. So basically it's this, and it's the same thing, the same rationale I use for regrowth. So for incomplete response and for regrowth.
Thank you. Dr. Simul Shah has a question. In wait and watch, is there any role for molecular markers and tumor markers?
Not that we have seen any benefit. We've studied the CEA already, and it's not specific and sensitive over anything. And the same with ctDNA. We've studied ctDNA on patients with watch and wait. And the truth is that the residual tumor that may have in some patients that will develop a local regrowth, sometimes they are so small that we can have a negative ctDNA and does not mean that you're not going to have a local regrowth. So when doing this study, we had patients with positive ctDNA that showed up to have systemic disease but not residual disease in the rectum, and patients with negative ctDNA that after a while end up having a local regrowth. So it's not something that's clear how to be used yet, and we do not use.
Thank you. Rakesh Bharat has some questions about the type of imaging. Once a patient has achieved a good response, what is the type of sequence of MR you prefer? Sequence of MR, is there any role of CEMR, and is there any role of PET scan also?
So we use the T2 weighting imagings with the dedicated protocol. Our radiologists also look at the diffusion imagings, but mainly the T2 to assess response. And there is not a clear role for the CE or the PET-MR so far, so we do not use it.
Thank you. And Rakesh is asking, is it the criteria to predict CCR on the lymph node? Is there any different imaging or the same MR where local regional assessment is same? Do you think to assess the lymph node status during follow-up MR is adequate?
So we use the same criteria for the MR that's used for the primary. So we need to see reduction in size. We have to see that the signal is getting more darker or low signal. And that's why it's so important to have the proper baseline study, because you want to know where the disease was, so you can look at it when you're reassessing the response. And basically the same as the primary.
Thank you. Senthil Kumar is asking, in your institution, the decision of wait and watch is taken upfront when the patient comes, or after you finished a TNT protocol, long course or whatever, and then you would take a decision?
So the decision of watch and wait is always after the end of the treatment and when the patient has a complete clinical response. What has changed is that the indication of TNT has changed. So while in the beginning we only had accidental watch and wait, which means patient that had TNT because of oncological reasons, because of having high risk features in the primary tumor, now we're doing TNT with the desire of doing watch and wait. But this is only a desire in the beginning. We just want to do watch and wait. We will only decide to do or not watch and wait after the end of the treatment and if we're facing a complete clinical response.
Thank you. Utkalika is asking, does the tumor histology affect the wait and watch? Like for example, patient had a signet cell carcinoma or poorly differentiated. What is your thought process on recruiting this patient for wait and watch?
So no, there is not clearly evidence showing that this patient has less chance or more chance of doing watch and wait. We have several patients that had previous mucinous tumors that had complete clinical response, and we include them in the watch and wait. And one interesting feature of this patient, and it's very common, that there are mucin deposits seen in the MR after the reassessment, and this can cause lots of confusion in us to offering watch and wait or no. But there are a few patients that we followed then, and the mucin deposit end up disappearing. But there is not a proper evidence showing that the one or other kind of histologic features has more or less chance of doing successful watch and wait.
Fantastic. Kiran Bagul is asking, if you are not using TNT, so there is an adjuvant chemotherapy after surgery. So during this course of adjuvant chemo, does it interfere in your response assessment, clinical follow-up of a patient on wait and watch?
So I'm not sure if I understand completely. So the adjuvant chemotherapy is performed after the operation. So usually if we're offering adjuvant chemotherapy, the patient has already been operated and there is no chance of doing watch and wait because he has already been operated. If we're doing TNT, we're doing the chemotherapy before the operation, and that's what we're using nowadays as the majority of everywhere. So we usually prefer for long course chemoradiation and then consolidation chemotherapy, which means chemotherapy between the radiotherapy and the decision to operate or not. And I believe the chemotherapy in this scenario has some impact in consolidating the response of the radiotherapy and perhaps giving, yes, more response, but it's not clear if it's the chemotherapy or the radiotherapy. The evidence we have more clearly is that the majority of the response is given by the radiotherapy and not the chemotherapy.
Thank you. Jay Verma has a question. Pre-chemo radiation, there was a frank infiltration into the sphincter, but patient achieved complete response as per the criteria you are laid on. Now, if there is a small regrowth in the mucosa away from the sphincter, this patient ends up with a APR with a permanent stoma or still a salvage surgery local possible. In other words, frank infiltration of sphincter, was it a contraindication for wait and watch?
Absolutely not. This is the best indication for watch and wait because this is the patient that would need a Milo's operation, an APR, and then a terminal colostomy. So if he has a complete clinical response, watch and wait. And if he has a local regrowth, probably the intersphincteric plane is already compromised because if it was a frank infiltration of the external sphincter, even though he had a complete clinical response, become all a dark signal. We cannot differentiate for fibrosis from a clear plane or from residual tumor. So if he has a regrowth, he will probably end up with a Miles operation, unless it's a very tiny local regrowth and we may eventually do a local excision to decide if we will continue with the Miles operation or not. But usually this patient will need the same operation than he needed in the beginning.
Thank you. So many questions are coming. I'll take this as a last question. Otherwise, they keep coming. This shows how important it is. Vishnu Kumar is asking, suppose some patient has an MRI incompatible implants. In old time, ortho implants or cardiac implants, if they were not MRI compatible, and they have achieved clinical complete response. So what alternative imaging we can use if MR cannot be done in those patients?
So we need to always get our radiologist involved. Okay, so we had already some patients with pacemaker that had a rectal tumor and he needs an MR. So I come to the radiologist and then the cardiologist, we need an MR. And the first answer will be, this is impossible. He has a pacemaker, but usually they can do it. Nowadays, there are many safe protocols that they can use to perform the MR. It's just we need to move them out of the comfort zone. I understand there may have some patient that cannot do the MR, and then we would do watch and wait if he had a complete clinical response without the MR. We need to remember that when Professor Angelita first started this in the 90s, there was not MR for anybody. MR was introduced in rectal cancer in the last decade, the end of the first decade of this century. So probably the first 15 years of watch and wait was without MR. We believe this is an extremely important tool nowadays, but the more important is digital rectal examination and endoscopy.
Fantastic. I think I'll end with last question. Rohit Kumar is asking, what is the compliance of your patient such intensive follow-up? Like, 2 months digital examination, imaging 3 to 4 months for first 3 years, and then 3 years they become little okay. So since you have a vast experience, can you come with a number? What percent of the patient actually comply for this intense follow-up who are kept on wait and watch?
It's really high. It's really high. And I must say that we also live in a continental country as India. And we also have patients that do not have the best financial facilities to move from one place to the other for the test and the follow-up. But they make every effort they can to come out for the follow-up because they know the other option would probably be an operation with a stoma. And so this watch and wait needs to be patient-driven. You cannot push a patient to do watch and wait. Usually you will say, you need this operation and there is a risk of stoma. And then the patient will say, oh, I don't want a stoma. And then you say, okay, we can talk about watch and wait. If he says, okay, do the stoma, there's no point of doing watch and wait, just do the operation. So this needs to be patient driven. If the patient is really involved and wants to have this successfully, they come back for the follow-up. And we have a very, very high compliance. I don't know the percentage, but I can tell you that's really, really high.
Fantastic. You can see the questions are popping in. That shows how much people are interested to get knowledge from you. But all good things, I always say there's all good things.
Discussions. It's really good to be with you.
Yeah, and almost all the subspecialties of India, right from top clinicians, consultants, clinical heads, students, everybody has logged in. This shows how interesting this topic. But as I always say, all good things has to come to an end, and the purpose of any of this knowledge sharing is to stimulate them. They also need to go expand, read, and come back. And then this actually shows that we have to invite you again back to India for a big oration, or probably we run a 3-day course of wait and watch from you and your colleagues. Thank you very much, and I would want to
join.
Thank you, and I want to end this and heartfelt thanks from myself and the national board for a wonderful talk, and then equally so much of patience in answering all the questions. And love from India to you and your team, and we hope to see you again and again. Thank you very much.
Thank you so much, sir. And thank you all attendees for being here. Thank you once again, sir.
Bye-bye. Bye-bye.
Pleasure. Bye-bye.